Centre for Sustainable Healthcare Women's Health Network. And you can see the link to the other networks here. So my husband pointed out that the Women's Health Network, he asked if men were invited. I hope that no one else is confused by our name, but it's about offering sustainable healthcare to women. As an obs and gynae doctor for years, I have thrown in at the end of my consultations with minimal input, diet and exercise. But now I realize that we have so much more to give than that. We see women at really poignant moments in their lives, fertility issues, pregnancy, during menopause, and then in the diagnosis of endometrial cancer. Lifestyle interventions not only have significant benefits for patients, but planetary health benefits and reducing the carbon footprint of the NHS. That's enough talking from me. I'm very excited this evening to introduce the speakers, Dr. Al Smith and Dr. Shireen Kassam. We're going to start the evening with Dr. Shireen Kassam, who is a consultant in hematologist and a certified lifestyle medicine physician. She's passionate about promoting healthy, sustainable diets and improving health and well-being, and tonight is going to give us a slant on this from a women's health point of view.
Great, thank you very much. Just going to share my slides. I think I'm unmuted. Here we go. Great, thank you very much. It's a real pleasure to be here. I don't normally get invited specifically to women's health events, so it's a lovely invitation. Just a few things about me, just a sort of disclosure slide. The things that are relevant and the reason I'm here is because as you just heard, I am certified in lifestyle medicine. I'm particularly passionate about using this knowledge for looking after my patients who with cancer, particularly lymphoma. And I'm founder and director of an organisation called Plant-Based Health Professionals UK. We provide education and advocacy on healthy plant-based diets, and I also provide this education on both the topics of plant-based diets and cancer at the University of Winchester. And for me, I guess, you know, sustainable healthcare means the healthcare we don't need. It's very much about preventing chronic conditions and empowering our patients to take back control of their health, something that we're not terribly good at doing, and only spend about 5% of the NHS budget on prevention when we know the vast majority of conditions could be prevented if we paid attention to lifestyle factors. So this talk, I'm going to take you through the consensus on diet, nutrition and health outcomes. I'm not particularly a women's health expert as such, so I'm going to focus on areas that I do feel expert to talk upon and that actually affect women considerably, but again, we don't talk about it as much as specific conditions around menopause, endometriosis, sort of women's cancers. So I'm going to talk about cardiovascular disease, cancer and brain health, but there'll be an overall theme. There's not one diet for a particular condition. It's the same healthy diet that supports us to live healthy, thrive and live throughout our long lives in good health. And then we'll point you to some further resources if I've sparked some interest in the topic. And we're here because we realise that we have a pandemic of preventable ill health. And this was really highlighted in a very recent report, just showing where we're headed to in 2040. It's terrible. We're living longer, although life expectancy has stagnated slightly, but we are living longer in ill health. So our health span is reducing, with people living 10 to 20 years at the end of their lives with chronic conditions on medication. And our diet is the leading cause of our chronic ill health and premature death. So dietary risk factors account for more illness than smoking and alcohol, for example. And the latest data show that unhealthy diets are responsible for about a quarter of deaths globally, a third of premature deaths in Europe. And clearly we're worried about this health of the planet and our rapid loss of biodiversity. And the food system in its entirety is creating around a third of all greenhouse gas emissions and the leading driver of biodiversity loss. When we think about health outcomes and causes of death and what we're suffering with at the latter years of our lives, it's the same for men and women, essentially. It's cardiovascular disease, cancer, and for women, Alzheimer's disease. So depending on what sort of listing you're looking at, Alzheimer's disease may come out top as a cause of death and disability in women particularly. But we know that 80% of our chronic conditions could be prevented or considerably delayed if we paid attention to healthy lifestyle factors, of which I'm going to talk about diet. And so when we look into what is wrong with our current diet, it's the same everywhere. So this applies to the UK. In this analysis of 195 regions around the world, researchers from the Global Burden of Disease Study Group found that dietary risk factors that were leading to ill health were particularly our diets are too high in sodiums, which is a reflection of our consumption of pre-prepared and packaged foods, and too low in the healthy plant foods which promote good health and prevent chronic disease. So we're not consuming enough fruits, vegetables, whole grains, beans, nuts and seeds. And this is leading to cardiovascular disease, cancer and type 2 diabetes. But we know a lot about what a healthy diet should be, and there is consensus despite the noise and misinformation in the mainstream media. This is a great paper just to refresh your knowledge on what we do know about healthy diet patterns. And just looking at the pyramid, it recognises that actually other healthy lifestyle behaviours like social interaction, spending time in nature, physical activity, adequate rest is just as important as a healthy diet. And a diet which is considered healthy is one that's centered around fruits, vegetables, whole grains, beans, nuts and seeds, mainly water for thirst, tea and coffee if you enjoy it, lots of herbs and spices, optional, but not necessary on a regular basis is fish and dairy, and really should be limited is meat, particularly red and processed meat and processed foods in general. And you can see that this type of diet is hugely adaptable to cultural and social norms. It's been tested as therapeutic diets. We've got numerous studies on the Mediterranean diet that focuses on healthy whole plant foods, plus the healthy lifestyle. We've got the dietary approaches to stop hypertension, DASH diet, that was particularly modelled around the vegetarian diet, and various other things. And it also includes a healthy plant-based diet, whether we term it vegetarian, vegan, or whole food plant-based. And for lifestyle medicine, the sort of fastest growing specialty globally, recognises that the ideal diet plan for preventing chronic conditions should be this: a whole food plant-based diet, half the plate of fruits and vegetables, a quarter whole grains, and a quarter plant sources of protein, so beans and nuts and lentils and soya. And as I say, lots of herbs and spices because they're delicious and because they add antioxidant and anti-inflammatory properties. And this type of diet is known to address the key drivers of chronic conditions that we're talking about today, both physical and mental health. So we know that most of our diseases are driven ultimately by inflammation, which is caused by unhealthy gut microbiome, adverse epigenetic changes, and cellular stress. But a plant-based diet really does impact all of these disease processes favorably. And the good news is that you can make an impactful change at any point in your life. So most of these things are reversible. So even if you're at that stage of having inflammation and certain chronic conditions, you can move back by using diet and lifestyle. And when we look at the overall data supporting the lifestyle recommendations of a healthy plant-based or plant-predominant diet, you can see from this table that I've put together 9 different studies just showing you the impact of a healthy plant-based diet with significant reductions in the biggest causes of chronic conditions and ill health: coronary heart disease, type 2 diabetes, cancer, stroke, renal failure, etc. Very recent study showed an association between plant-based diets and a reduction in Parkinson's disease, and showing us that we can live longer and better free of chronic disease, so reduction in premature mortality. And this is part of all our guidelines. So starting from the left, you can see American Cardiology, American College of Cardiology, and the American Heart Associations recommends Mediterranean, DASH, or healthy vegetarian or exclusively plant-based diet. So plant-based variation of what suits you. Similarly, for my specialty of cancer, eat a diet rich in fruits, vegetables, whole grains, beans, nuts and seeds. And similarly, very recently, We've got guidelines from European consensus document on management of diabetes, focusing on minimally processed fibre-rich plant foods. And so just to look at like how we've come to this recommendation, just on a very basic level, and I hope you've all watched the Netflix documentary. It's 3 parts called Live to 100, I think it's called, outlining the work of Dan Buettner, who coined the term the blue zones, where people live the longest and healthiest lives. And here you can see a centenarian in Okinawa. There are 5 regions around the world where people are more likely to reach 100 years of age in good health. And when you deep dive into what they're eating, which is one of the 9 factors they share in common, you can see it's almost a plant-based, so 90 to 100% plant-based, depending on which blue zone you look at. Going whole, meaning you don't consume lots of processed foods. Daily dose of beans is key, mostly water for thirst, snack on nuts, go easy on fish, eliminate eggs, slash the sugar, reduce the dairy, and retreat from meat. So similar to what the guidelines show. Now, if you look specifically at cardiovascular disease and coronary heart disease, which remains the top killer of men and women globally, there are 9 risk factors that account for 90% of heart disease. That means that 90% of heart disease could be prevented if we paid attention to all of these risk factors. And in bold, I've highlighted those that are related to dietary risk factors. So abnormal lipids, hypertension, diabetes, all related to the diet predominantly, alongside other lifestyle factors. But if we get diet right, we are really along the right path. And a healthy diet in this context of cardiovascular disease is low in energy, high in fibre, low in saturated fat, full of antioxidants and micronutrients such as vitamins and minerals, free of harmful compounds, things like saturated fat, heme, iron, and so forth, and promotes a healthy gut microbiome. And this is essentially, these criteria are met by eating a diet full of a variety of plant foods. And here is just a diagram of showing you what can happen in a positive way if we swap out saturated fat found predominantly in animal-based foods for unsaturated sources of fat found in plant sources. You can really reduce LDL cholesterol, which is the main driver of cardiovascular disease. And if you look at prospective cohort studies, this is an example of the health professional study and the nurses' health study. More than 200,000 men and women followed for over 30 years. The impact of eating a healthy plant-based diet compared to an omnivorous diet is that you reduce your risk by about 25 to 30%. But a word of caution, if you're concentrating on unhealthy plant foods like juices and refined grains and sugar-sweetened beverages, then that increases your risk. So diet quality is paramount. So just shifting gear over to my area of specialty, which is cancer. And there's clear guidance, this is from 2018, that we could prevent 4 in 10 or 40% of cancers if we paid attention to modifiable risk factors. Be a healthy weight, physical activity, eat a diet rich in whole grains, vegetables, fruits, and beans. So a plant-based diet. Limit fast food, red and processed meat, and I'd say avoid red and processed meat. We all know that its production is really unsustainable for the planet, but also processed red meat has been deemed a group 1 carcinogen and unprocessed meat a probable group 2 carcinogen. Avoid sugar-sweetened beverages. Limit alcohol, I'd say avoid. There's no safe limit when it comes to certain cancers like breast cancer, for example. Don't use supplements, use diet first to get your nutrition, and breastfeed if you can if you're a mum, because there's benefits to baby and mum. Mum will have a reduced risk of breast cancer in the future. And after a cancer diagnosis, follow these recommendations. And it's not really any surprise that 5 out of these 10 recommendations are directly related to dietary risk factors. And they really do work. If you look at an analysis just published recently, 18 studies brought together to show what the impact of following these recommendations are on cancer risk over a long period of time. And of course, populations don't really follow these guidelines. So that's why the impact isn't as high as you might expect. However, there's significant reductions in risk of breast cancer by about 1/4, colorectal cancer, lung cancer, and with each additional healthy recommendation that you adhere to, there's a 10% reduction in cancer risk. So any move towards following these guidelines are good. And just keeping an eye on time, sorry. So then when you look at diet patterns, there's a big study published from the UK Biobank data set. 500,000 participants followed for over 11 years looking at different diet patterns, and the data is consistent with other published studies in that meat-free diets generally associated with a lower risk of various cancers. And although I like to talk about diet patterns and emphasizing a variety of plant foods, what's key for cancer is making sure we incorporate the foods that have been particularly researched and independently associated with a lower risk of cancer. So we'll come back to soya shortly, but mushrooms and the lycopene-rich bright red fruits and vegetables, cruciferous vegetables, onions and leeks and garlic, which are rich in organosulfur compounds, and the dark berries. So incorporating all of these types of foods regularly is really key. And think about a portion of nuts. Not only is it great for cardiovascular disease, it reduces risk of cancer. Lots of herbs and spices, as I've said, and turmeric is kind of the queen of spices, given the curcumin associated with many health benefits, including reduced risk of cancer. Coffee is good if you enjoy it, as is tea. If you don't, then that's fine, but you shouldn't shy away from that. And flax seeds are a great source of omega-3 fatty acids in a plant-based diet, but rich in fibre and lignans, which are associated with a reduced risk of cancer. So just changing track once again to my final condition that I wanted to highlight, a similar theme here, dementia. 12 risk factors are associated with an increased risk of developing Alzheimer's dementia and also vascular dementia. And if we were able to address all of these, we could prevent 40% of cases, which would be remarkable. And again, dietary risk factors are really important because they drive hypertension and type 2 diabetes. Alcohol consumption is important to limit or avoid when it comes to brain health, maintaining a healthy weight. And in general, the kind of Mediterranean diet pattern is recommended by the WHO, rich in plant foods, healthy plant fats, and other sources of omega-3 fats, and low in saturated fat and meat in general. And when we look at what nutrients and foods are particularly good for preventing dementia, it's the leafy green vegetables that stand out when you're picking out vegetables. It's a variety of plant foods. It's the healthy unsaturated fats from olive oil, from avocados, seeds and nuts, the flavonoids in berries, particularly fiber in all the plant foods, and tea and coffee, as I say, if you enjoy it, it seems to be of benefit to brain health. But the things that stand out in all of these conditions to really limit or avoid are the red and processed meat, diets high in salt, diet high in free sugar, and alcohol. I just wanted to highlight soya as a really healthy food, particularly for women's health, but for everybody. And it's something that the British public don't consume a lot of unless it's in a processed form. So here we're talking about minimally processed soya, such as tofu, tempeh, edamame, and soya milk. It's got a unique nutritional profile. If people are still worried about complete protein, you shouldn't be. But if you are, then soya has exactly the same sort of biologically complete protein as animal foods. It has fiber, it's high in unsaturated fats, and it has particular compounds called isoflavones that really do benefit our health. And we should really be incorporating soya in its minimal form on a daily basis. So for breast cancer, there's clear data that it has positive anti-estrogenic properties, and it reduces risk of breast cancer, particularly if you start consuming soya in adolescence. It can reduce recurrence and improve survival after a diagnosis of breast cancer. And there's been a huge umbrella study of randomized controlled trials, just demonstrating the power of soya within the diet, but particularly for cancers as well. And you can see there's multiple benefits for reducing cancers in both men and women. And I didn't highlight the other benefits, but really for every body organ, cardiovascular disease, brain health, etc., there are benefits of consuming soya. And this is a great study published last year from the US, looking at the impact of a plant-based diet with additional whole soya beans, about 80 grams a day, which is a portion's worth. And this was really beneficial in reducing hot flashes in women, reduced their severity by 84% in the intervention group. And one of the ways that it might do this is by reducing dietary advanced glycation end products, which are caused by certain foods and heating foods at high temperatures. But this type of plant-based diet with soya is lower in dietary AGEs and was associated with lowering of the frequency of hot flashes. So just in the last few minutes, I just wanted to cover how the best diet for health is not in conflict with the best diet for our planet and for restoring biodiversity. You'll all be familiar with the Eat Lancet Planetary Health Plate. This brought together 36 different scientists from different aspects of looking at health, from climate to individual health, from 16 different countries around the world. And they came up with a diet that would not only support keeping the food system within planetary boundaries, of which we've already breached, but would help us keep within planetary boundaries, and would help us save the 11 million premature deaths that are occurring due to dietary risk factors. And here you can see the plate is very similar to what I've been showing you throughout this talk: half fruits and vegetables, about nearly a quarter whole grains, getting your protein from plant sources. If you're eating, when you're thinking about vegetables, starchy vegetables should be minimized for health purposes. It's better to concentrate on non-starchy vegetables, getting your fats from unsaturated sources. So that's mainly from the plant-based sources. And it's quite clear that animal foods, dairy and meat are optional, but if you do consume them, it shouldn't be more than 1 portion of red meat a week, 2 portions of poultry and 3 eggs per week. And dairy is really not considered necessary, and of course 70% of the world's population is in fact intolerant to lactose anyway, so it's of no relevance to them. And if you look at the co-benefits, this is the largest study to look at the health impacts and the environmental impacts. If we were to all adopt the Eat Lancet Planetary Health diet, and they looked at 10 countries, nearly 500,000 participants, and they showed that this type of diet was predicted to reduce premature mortality by 60%, reduce the risk of cancer by 40%, whilst at the same time reducing greenhouse gas emissions from the food system by 50% and land use by 62%. And this land can obviously go to restoring nature and capturing carbon. So I hope in this very brief period of time, I've given you some information about the large body of evidence supporting a plant-based diet for improving health outcomes, and that relates to women's health. There is no different diet for men and women or for different health conditions. That national and international guidelines are catching up, so the Eat Lancet Planetary Health Plate, but I could have shown you country-based guidelines that are also recommending the same, and that we can't think about our human health without thinking about global planetary health. And so if you want to learn more, this is a few of the things that I'm up to. I teach this online course at the University of Winchester, which is CPD accredited. We've just launched this course, which is you can still probably book onto. It starts on the 17th of October on the application of lifestyle medicine interventions for preventing cancer, improving survivorship. If you haven't already watched this documentary, it brings together everything I've been talking about, called Eating Our Way to Extinction. It's now free on YouTube. We have a 21-day plant-based health challenge, so you can scan that right now if you want to, or just look at our website, pbhp.uk/21-day. And we've got a new podcast. 2 of our GP members at Plant-Based Health Professionals are putting together in bite-sized portions some actionable evidence that you can put into your own practice, either for yourself, your families, your communities, or your patients. So do listen in to In a Nutshell, available all on the usual platforms. And these are 2 of the books that I've been involved in writing over the last couple of years. So I think that's it, and I'm very happy to take some questions.
Thank you, Shireen, for a really excellent talk. I would like to start off the questions, if that's okay. How do you advise getting dietary advice on a plant-based diet into your consultations? Because I was in a gynecology clinic this afternoon and had a patient with fertility issues. I had minimal to offer her from a gynecological point of view, but I really felt like she would have benefited from lifestyle interventions.
Yeah,
but
no,
I don't know how to.
Yes, thank you. It's a really great question. And I guess there's few aspects to think about. So for me in cancer, everyone asks me, what can I do? Is there, what should I eat? So it's quite easy to initiate the conversation. It's really useful to get an idea of people's baseline diets, just in a sort of general sense. So asking people how many portions of fruits and vegetables they eat a day, how often do they cook at home? Are they eating mainly processed foods or home cooked foods? And thinking about, refined carbohydrates. So just having a few questions just to gauge where you can add some value in that short period of time. I would then, as we know, our patients are way away from the ideal diet. So just making some simple recommendations to get them thinking about changing their diet. So adding in an extra portion of fruits and vegetables. And we know we should be asking people to make actionable changes. So using sort of SMART criteria just to sort of write a little prescription and give them some advice. So just thinking, so I focus in on adding fruits and vegetables. I suggest trying out some soya foods because it's so healthy on many aspects, and swapping in or out refined grains for whole grains. So just thinking about those few things, and then just having some readily available resources. So for example, for fertility, the BDA have a really great fact sheet on what to eat. It was actually written by one of our plant-based health professionals members, a registered dietitian. I can pop it in the chat in a moment. So I think just having a little handout that's relevant for your specialty can just help guide. So whether it's written, a little video, a book to recommend, and that's probably all I can fit in the first consultation. And then, if you are going to see people again, you're able to follow that up. But small things, actionable, try and make it relevant for their their context, whether it's financial, socioeconomic, etc.
Thank you. Liz Murphy, would you like to ask a question?
Yeah, thanks, Amy. I'm a nurse and midwife, and I'm also part of the Women's Network and working in sustainability at the moment as well. So it was interesting to see the slide that had air pollution related to dementia as well, which is a project that we're looking at the moment. And also really heartening to see the microbiome featured in your presentation, which seems to be having a lot of traction at the minute because of the Zoe study and the Zoe podcast and things like that happening. It was just a personal kind of familial question that I wanted to ask you. High cholesterol in my family, lots of my aunties on statins who have made dietary changes and have got side effects and aren't particularly comfortable with statins. In your experience, have you seen people reverse that with diet and stop taking statins? Because I've never had that answer from any of the GPs that I've spoken to.
Yes, so I do know that is possible, but each sort of person is individual. And of course, people do have genetic causes of slightly higher LDL cholesterol. And I guess there may be, based on other risk factors, reasons to lower cholesterol further than you might get with diet alone. So again, I'll pop it in the chat in a moment. But when you look at therapeutic interventions for high cholesterol, we know the impacts are additive, and so for each sort of dietary change you make that we know results in a lower LDL cholesterol, you can lower your LDL cholesterol by about 5 to 10%. And so overall, the portfolio dietary pattern, which is really the main therapeutic diet for lowering cholesterol, can result in about a 30% reduction of your cholesterol if you're sticking to it very closely. Now, obviously, in the real world, people may not adhere as well as one might like. And so in the real world setting, you get about a 15 to 20% reduction, which is great, but it kind of depends on where you're starting. So the answer to your question is yes, but everyone's sort of baseline, it can be different, and you can't get everyone off. And I think we should be using every tool in our toolbox. So I'm not against using a statin, and I do believe that we do need to lower LDL cholesterol, the lower the better. But diet and lifestyle really has a profound impact. So that should be the starting point. And then if people can't get there for various reasons, then adding in drugs. But yes, people can absolutely lower their cholesterol through diet and lifestyle approaches. Diet's not the only factor, and you'll be hearing from Ralph, I'm sure, how important physical activity is too.
Great, that's really refreshing. Thank you.
One more question for Shireen from the chat. How would you balance eating for personal health with eating for the planet? So in the UK, things like berries and greens are only available during the summer or spring months. In the winter, they're probably going to be air freighted. So can we advocate for these things year round?
Yeah, so I think we have to do...
Concerns over soy, monoculture of soya as well.
Yes, so two questions there. I think we have to do the best we can, but I think we have to be clear with where the evidence lies. It's more about what you eat rather than where it comes from, how it's produced, is making the biggest impact. And if you guys haven't seen it already, one of the largest studies looking at all of these factors came out recently, analysing the EPIC Oxford dietary data set, showing that really 100% plant-based diet, regardless of where and how the food has come from and produced, is the most impactful action we can take. And there were headlines saying, we can take 8 million cars off the road if we all went vegan. And so I think we need to be clear on that. And then, yes, if we've all got to that point, which would be amazing, we would have reduced food system greenhouse gas emissions by 50% and freed up 75% of farmland if we all adopted a plant-based diet. Then we can start worrying about production and how far our food is traveling. So travel is generally less than 10% of the overall impact, environmental impact. Soya monocultures. So 7% of soya grown globally is used for human consumption. 70% goes to feeding farm animals and the rest to biofuels. When you go to the supermarket and buy your Alpro soya milk or whatever, that's grown in Europe or Canada. It's not coming from the Amazon forest. So the main concern around soya production is deforestation for cattle grazing and also growing soya for animal food. So again, that's a little bit of a myth that's perpetuated. Monocultures are being driven by the desire to use the products like wheat and corn and soya for feeding animals. So yes, we have to change the way we farm, and that's perhaps another talk you'd like to schedule about how we need to change the way we produce food from a farming system that's heavily dependent on tillage, monocultures, and various other things. We need to develop an ecological sound way of farming, but that's different from the way you choose your foods. And shifting to a plant-based diet doesn't negate any of those issues. It helps support lowering the production of all of those grains that are being produced in a monoculture form to feed animals, which is at least a third of all grains that are produced.
Thank you. And I think the other myth that I've heard you talk about before was there are things in meat, the nutrients in meat that you can't get from a plant-based diet.
Yeah, well, I mean, obviously we know B12, and if you're on a 100% plant-based diet, vegan diet, you need a vitamin B12 supplement. But there's a really great study looking at how far you can get on an omnivorous diet towards a plant-based diet before you start needing any sort of supplements. And we could all shift to 80% of our protein from plant sources before we even worry about that. So if we all think of our kind of baseline diet and shift at least 80%, we would be in such a better position than we are now. And yes, so vegan diet, vitamin B12 supplement, but we're just removing the kind of middle animal, as it were, who's already been supplemented, and then we consume the animal that has been supplemented with vitamin B12.
Thank you, Shireen, for a very valuable talk. We'll now move on to our second speaker, Dr. Ralph Smith, who is a consultant in sports and exercise medicine in Oxford. He's published internationally on many different subjects and is going to talk to us tonight specifically about his work looking at physical activity and gestational diabetes. Thank you.
Brilliant. Thank you very much. I'm just going to get the slides up and let me know when you can see them. Is that all good? Yeah, brilliant. Yeah, so thanks for Alice and Amy for asking me to speak tonight and for the network. I'm really grateful to be here and talk about really as a whistle-stop tour through my journey with physical activity in pregnancy, and then looking at particularly in gestational diabetes, some of the work I've done there. The work that I've been involved with, some of it's been lottery funded, some of it's been through the BRC in Oxford. I've worked closely with the Faculty of Sports and Exercise Medicine, obviously the University Hospitals in Oxford, where I work as a sports and exercise medicine consultant, which is a fairly new specialty looking at promoting musculoskeletal health and also promoting physical activity and trying to get everyone a bit more active, because we know that keeping active is so important and can help with so many different health benefits. So I really started getting involved in this when I was a registrar doing my public health attachment, and I helped design the physical activity infographic, which is shown here with the for pregnant women. And so for those of you who don't know, we recommend throughout pregnancy, women should be aiming for at least 150 minutes of moderate intensity activity, and then doing about 2 strength sessions a week. But there's a variety of different activities shown that they can do. It's anything from carrying bags to yoga, personal training sessions, swimming, and keeping moving, really. And it's just about doing as much movement as they can, really. And physical activity specific for pregnancy has some really good benefits for helping control their gestational weight, improving and helping control blood pressure. There's some good evidence around preventing gestational diabetes. And then when I go on to talk about gestational diabetes in detail, a bit more about how we can control blood sugars and insulin levels with physical activity. Overall, it improves your fitness, and then general benefits for everyone, as we all know, often improves your mood and sleep. And then the kind of we came up with a couple of lines, including there's no evidence of harm. Listen to your body and adapt your activity, and the phrase that was very debated about was don't bump the bump. And then we had a similar time about 6 months later, published was the Canadian guidelines about physical activity throughout pregnancy as well, which really echoed all the statements we had from the Chief Medical Officer's infographic. So that's a really good resource to go to have a look at and have some positive conversations with women about physical activity. So I spent hours and days making this infographic and helping design it. But I kind of went back to the hospital and realized that no one was really talking about it, and no one was using it, and no one had even heard of it or seen of it. So that was quite a kind of a shock, and I realized I was in a bit of a bubble, really. And I kind of realized that during pregnancy, it's a huge opportunity here. You have people who are quite motivated. They have a real access to healthcare professionals. Not often during your time in your life do you see healthcare professionals so regularly as during your pregnancy. But if you look at the guidance, depending on where you read, about less than 25% of pregnant women are meeting the physical activity guidelines, and this declines through pregnancy. And we've got, as you were aware, those who are working in maternity and obstetric services, that there are increasing complications, both maternal and obstetric complications that, keep physical activity can make a big difference to try and prevent some of those. Then when we looked at healthcare professionals, we realised that they kind of lack confidence to talk about physical activity. They feel under-resourced, and concerns about safety and inadequate training, and as a result, pregnant women often get kind of vague and inconsistent and conflicting advice. So that was where the Chief Medical Officer's guidance was first born and developed from that initial work. So hopefully those of you may know about the Moving Medicine website, which is a website which has lots of different conditions, looking at all the different kind of non-communicable diseases, as well as pregnancy and postnatal, and lots of other tools to have consultation guides with. And so there's the pregnancy one, which you can have a 1-minute conversation, a 5-minute conversation, or more minute conversations. You can really incorporate that into your consultations, and it's a nice tool, an online tool of how to use it. And I'll just show you this, like an extract from the 1-minute consultation. And it's always difficult to have these conversations. You always have back and forth with patients, and it can get very difficult. But I've always found if you start off in the consultation, maybe it's just you've got a couple of minutes at the end, it's just ask their permission. Is it okay if I get your thoughts and feelings about something we feel is quite important for your health? Or would it be okay if we spend a few minutes talking about something many patients who are pregnant find really helpful? And that can really just start off the conversation and gets you on the right foot, because sometimes lifestyle things can be quite challenging to have those conversations. So moving on to that was initially, and then we had this opportunity with Public Health England looking at introducing physical activity into secondary care, and Oxford was chosen as one of the pilot areas and the pilot site. And I was lucky enough to, having done the work in the maternity, having done the work with the infographic with the Chief Medical Officer during my public health attachment, I then had an opportunity to then try and implement some more practical things within the maternity department. And I'll take you through some of those things. So we wanted to really direct influence women through patient encounters directly, through their environment that they come to in the hospital, and through some technology, which I'll talk about towards the end. We want to develop some more resources for healthcare professionals to use and feel more confident with and what to go to. And then also try and influence staff, culture, and governance around physical activity, including giving more education, implementing some things in systems, and changing culture about activity and making a supportive network for people. And this was our team. So we had a pilot project which ran for about 18 months. And we had we had a very interested maternity consultant, Lucy McKillop, who was very helpful in helping design and aid this. We had a physical activity midwife champion that sat in the middle between the two teams, and we had some senior midwives also helping us. We chose to look across the patient journey and looking at their booking, scan appointments, and through their and we specifically looked at the gestational diabetes clinic. And we had plans to also look at the lifestyle clinic, which is for women with a BMI of over 35, and the health and the Silver Star clinic, which is women with kind of more complicated obstetric problems. And above that, we looked at kind of encompassing staff training, governance, and things like that, and promoting a culture, as I've mentioned. So this is our intervention in booking. So this was quite challenging to implement, and as probably many midwives on the call will appreciate, booking appointment is very busy, and there's lots of questions to ask and lots of things to go through. But we managed to persuade our team to put in a physical activity calculator, and it wasn't really because we wanted to know what levels of physical activity there were, but it was just to try and promote a bit of a conversation about it, or at least signpost them. But the way we did it was we adapted something called the exercise vital sign, which basically looks at how many days a week you engage in moderate activity, more than a brisk walk for more than 10 minutes, and how many minutes you do that activity for. And it gives you a rough calculation of how many minutes, and it gives you a kind of a traffic light system to try and guide patients with. And we know that in early pregnancy that increased activity can improve pregnancy health, and there's some good literature on that. We developed some supporting material to support the midwives when having those conversations. And so this has been going for 45 months now since we launched the project, and it's still in the booking at the moment. And we've had over 32,000 women have been through and had these questions asked, and recording data all the time about it. And if you look at it, about 60% are meeting the physical activity recommendations of that kind of 150 minutes. Whilst I would say this is self-reported data, not very accurate and asked during the booking system, it does kind of give the similar representation to what national figures are for just non-pregnant women as well. But if you look at it, an eighth of women are doing less than 30 minutes of activity a week, or they admit to doing at least which is actually a lot, and very low. That's doing less than 30 minutes a week. So moving on from the booking appointment, we looked at changing some of the things in the environment. We made a promotional film, which I think Alice is going to send the link around to show people. We made promotional posters in the waiting area, and we made some leaflets. We revamped the trust leaflets. We did a staff education session where we got different staff to come through, and we got some good positive feedbacks from there. We went all with community midwives and also spoke to them about physical activity and had sessions on that. And that was really positive. We had lots of delegates who were midwives. Most of them hadn't had any formal training in physical activity before. And we got some really positive outcomes from that as well, seeing people getting increased in confidence, more motivated to speak about physical activity, which was great. And then we went on to do a bit more of a specific intervention in the gestational diabetes clinic. And the reason we chose gestational diabetes is there's probably some really good evidence base that gestational physical activity can help improve glycemic control. These women are often quite motivated to do anything they can to change. They often get diagnosed in the end stage of their pregnancy, and they're keen to stay off medication, and lifestyle interventions are very helpful. And yeah, there's been some, with conjunction with other lifestyle things, we noticed it can have some improved outcomes, including reducing the risk of being born large gestational age, postnatal depression, and other aspects. The NICE guidelines, which is probably a bit outdated now, but does recommend at least 30 minutes after a meal to improve glycemic control. So it's a kind of key part in your management in the gestational diabetes, and it probably needs more attention, even more attention than it gets at the moment. And in Oxford, we had specific dedicated sessions for that. We know that it improves glycemic control and reduces insulin requirements. We've done some qualitative work's been done by Harrison, and they find that they need clear, simple advice about and kind of quite specific messages about physical activity from credible options and they're quite flexible as well. And we can see that from PA interventions are significantly underutilized, with lots of women not meeting the guidelines. Up to 65% of women are not meeting the recommended guidelines with gestational diabetes, and only 6% reported healthcare professionals they reported that was their source of it for exercise information. So women weren't being informed. So how do we go about kind of fundamental to how do we go about kind of physical activity interventions? And really the work by Susan Mickey and things like behavior change intervention techniques are kind of fundamental to that, addressing personal barriers and enablers. And motivation interviewing is one of those, a tool that really offers a number of different things, and it can be used for a number of different chronic diseases. It's been shown to be quite helpful with reducing alcohol consumption and improving healthy behaviors, and was used also in kind of smoking cessation as well. And pregnant women are quite a motivated group over a short period of time to receive a motivation interview that might help them change some of their lifestyles. So in the clinic, this is at the end of the kind of active hospitals pilots in the secondary care. We had a clinical champion. We worked with the dietetic services, and on top of the dietitian discussions they also had an additional physical activity. They got an offer to have a one-to-one motivation interviewing, where they often set goals, and then there's an activity planner and a community navigator who would help them find activities local to them. We redesigned the pregnancy leaflets within the clinic, and we kind of worked with the staff to try and help women and supported them through their journey in the gestational diabetes clinic. And there's a gestational diabetes app called GDM Health, which is used across trusts, that helps track blood sugars and has reduced consultations because it's a remote monitoring system. And we were hoping to link with them in the future as well. So that intervention was already used in the clinic. So we introduced this motivation interviewing as part of it, and it was actually quite successful. And this started the initial part of the research where we started to look at more having a motivation interview with women. And we trained up 2 midwives, and we had about a 20-minute interview discussing lots of different bits, including sharing the importance of activity, building their confidence, sharing some of the benefits, coming up with an action plan and goal setting. And then we had a 2-week call post-interview, and we did some work looking at their physical activity self-reported levels. This is just an example of the structure of the motivation interview. It's all been published online, and it's in the Journal of Midwifery, and the reference is down at the bottom. So yeah, that was the kind of the format of the conversation. And actually we had some really improvement in levels and self-reported levels, which was really positive. And this was really great. We thought, excellent, we've now managed to start having some positive conversations about physical activity, but we can't really sustain this remotely and at scale. So what can we do next? And we had a think. Just from this, it was really positive, some of the feedback we got from the teams. That was, the telephone support was really helpful. Women were looking at their blood sugar levels, looking at activity, and realizing that it could make a big difference for them. And it was partners also very supportive, and it was really quite impressive the way people were responding to it. So it was good. So we looked at how we could kind of maintain physical activity and support, and we because we already had a smartphone application already, was the GDM Health app, which is the remote monitoring blood sugars through an app. We thought that we could try and make a physical activity one, and so this was the next part of my research, where we and looking at there's lots of apps out there. There's some good study that it's shown that that mobile phones apps and brief counselling can objectively improve physical activity over 3 months. We already had this successful GDM Health app looking at blood sugars within the clinic, and hopefully we'd like to in the future combine with them. And it's something that we could do remotely. So this is a nice diagram by Flannery, or it just really shows that all the different physical activity behaviours, the barriers and enablers for women, and it's a really nice example of looking at different areas and how we need to support them widely. For example, giving them more information on the benefits of physical activity, making a plan, monitoring their progress, and changing the social norms about being physically active during pregnancy. Many cultures, look at resting during pregnancy, and which can be quite counterproductive. So we used the behavior change wheel, which I won't bore you with too much, but we used this designed by Susan Mickey, which looks at capability, opportunity, and motivation, something called the COM-B model, and then used 10 behavior. We came up with 10. You put the input into the wheel, and you basically come up with 10 behavioral change techniques that we can use. And we used evidence, we used focus groups to design this app. And we've published a paper about how we designed it, and that's published in the BMC and pregnancy and childbirth. So this is a couple of snippets from the app that looks at it. We look at performance feedback. It has a wheel of how much activity they've done. It has a message center. It has a resource center about gestational diabetes, and looking at all those different behavioral techniques. And then it has, within the resource center, there's lots of information they can find, and there's different exercises, a basic home exercise program, because we found that women were very keen on having exercise they could do at home, didn't have to go to the gym. And then the local activities specifically for pregnancy, they could look at using the NHS supplied finder, which is actually really good, but no one knew about it. So that was great to kind of create that. They set goals with the midwife from the motivation interview, and then those 3 goals come up on the app, and they can tick them off of what they've done, and then they get some stars when they've completed them. This lady, for example, is doing jogging for 15 minutes, yoga for 30 minutes, and Zumba 3 days a week. And when she's done it, she slides it off, and it gives you a good feedback message, which hopefully isn't too patronizing. So there's the kind of promotional messages and cues, which is all part of the behavior change wheel. And and then we have a message center where the midwives can message the women directly when they've looked at what activity they've signed off, to say, well done, you're doing great. And we do that probably twice a week. And we're able to manage a number of women during our feasibility study remotely, and supporting them with physical activity. This is this dashboard. This is from the midwives' point of view. So there are two midwives who've done the motivation interviewing. They then support the women through that using this app, and giving them pointers, giving them and resetting some of their activity goals during that time. And they have a conversation maybe once every 2 weeks, and reset some of those and adjust things and be supportive to them. We've published that study protocol about how we've designed this feasibility study to go forward. And this is just a little bit about it. I won't go through it too much because it's all been published. But we basically recruited women at the gestational diabetes clinic. We did some physical activity questionnaires. They then had a motivation interviewing, and we set up the app. They then recorded their goals and supported them through that using the app with weekly telephone calls, adjusting goals and adapting things with regular messaging. And then we reviewed their physical activity levels and kind of satisfaction at 36 weeks. Primary outcomes looking at recruiting and retention, compliance and engagement. And secondary outcomes were the bits that we obviously, because it was just a feasibility study, we looked at kind of glucose monitoring, assessment of their control, how satisfied they were with the how satisfied they were, looking at their self-reported physical activity levels, usage and feedback, and kind of descriptions of, looked at some of the maternal outcomes. Sure. So hopefully I've given you a bit of a summary through the kind of work I did, looking at the Active Hospital project, looking at the kind of booking work we've done, looking at some of the tools we've put in place to try and promote physical activity in our service in the OUH, the maternity department, and the work around the gestational diabetes. Hopefully giving you a flavour of how you can develop a complex intervention for physical activity, designing a smartphone app, and looking a bit more at the feasibility trial we've got. Unfortunately, I can't share any of the data. The feasibility trial study is now finished, but I can't share any of the data because it's just under review at the moment to be published, but hopefully should be published shortly. But as soon as that comes out, I'm very happy to share that the findings, which I think will be very positive with the group. And I can share the link to the paper. So just to finish with, I just wanted to remind you about the Moving Medicine physical activity conversations, and pregnancies is on there as one to look at. And if you're wanting to have better conversations about physical activity with women, I think this would be the first place I'd have a look at, which can be really positive. It goes through all the different benefits, has all the evidence-based. This is not for patients, this is for healthcare professionals to have those better conversations. But often patients find them quite useful, but there are patient leaflets on there as well. But you can also, I'm very happy for you to, you can also find the OUH ones very easily as well, which we've written. And then this is the Active Hospitals website, which looks at which is on Moving Medicine as well. So and this is the maternity department, and gives an example of the work we've done within the maternity pathway, which I'll just kind of run through quickly. It goes through the pathway that we used, including the booking, the scan appointments, gestational diabetes clinic, and then breaks down all those interventions and has a bit more information about each of them. So, for example, if you wanted to start doing some of this in your hospital and what interventions you could look at, this is a great resource for you to get some ideas and contact. And Lacey, who runs and is very helpful, who's an administrator, will be very happy to, I'm sure, to help support you as well. And then the last thing that I've been asked to promote is about the Active Conversations course. Having conversations about physical activity can be really challenging, and you can have some not so positive ones. So the active conversation course is really great. It's a CPD course. There's two. I understand there's two different ones you can do, which run through kind of over a course of weeks. Doing different modules and talking, having these positive conversations about physical activity. If you sign up before Monday, using the early bird code, I understand you can get 10% off. Great. So I think I've probably spoken enough now, and I'm very happy to take any questions or let everyone head off for the evening.
Thank you, Ralph, for a really excellent talk. It's something I'm very passionate about, so I was very pleased to hear you talk about it. I have seen the infographic, and it's very good, and it is up and around the hospitals that I work in. I've also completed the Moving Medicines Active Conversations course that you talked about, and I found it made a huge difference to my practice. I don't remember receiving any training at medical school about motivational interviewing, and it's really helped me not only in pregnancy but those conversations with women with high BMI who you might see with incontinence problems. I now feel like I can offer them something instead of just saying no, you can't have surgery. My question would be, the app, obviously you've just run the pilot study, but after that, would there be a plan to make it available to other departments?
Yeah, I mean, I think we'd ultimately we'd need to run a randomized control study after that, after the feasibility study, and at the moment my funding related to that I haven't managed to secure another grant, but that would be the next stage, would be to have a randomized control study to look at outcomes and prove that it's successful. But the other thing that I'd be really excited to do is to eventually merge an app which would combine that, the GDM Health app, for example, which is the one that women download in the clinic, so to monitor their blood sugar levels. So that's a remote monitoring system where they use a Bluetooth monitor for their blood sugar levels. So it takes their blood sugar levels and then it stores it directly on an app, which the hospital midwives can see their results directly and can save appointments, can track their blood sugar levels, can actually often prompt for prescription of medication, like to start metformin and things like that, through the app. So it's and I'd like to combine that further. That would be the ultimate goal, I think, to be able to combine those two together, because you then get kind of real time, with physical activity combining with blood sugar monitoring, and this kind of key point, because I know many decisions in maternity care around gestational diabetes are related to glycemic control.
Thank you. Also on the app, I was wondering, you talked about the different activities from a sustainability point of view. Is there a section for active transport for persuading women to switch, from driving their kids to school, maybe to walking with them, that kind of conversation?
We that's a very good point, actually. That's probably something we probably need to put more on. We've kind of always look. There's a bit about kind of looking at different ways to travel, and the video that we haven't shown actually this evening that does have a bit about that, about changing different ways to travel. And I think that is definitely a way forward, especially with the other aspects of sustainability that you mentioned. Yeah.
See, Alice has her hand up.
So I was just going to read a question that's been put into the chat, which is from Claire. Is there a level or type of physical activity that you would not recommend, and would the recommendations change based on trimester? For example, jogging in first trimester quite different to third.
So yeah, we often get asked about this, and the pretty much most activities are okay. There are a few activities you wouldn't do, and they're things like that are high risk of trauma, for example, where we tend to advise against kind of horse riding, or kind of trauma impact activities such as we also say it's best to start, listen to your body and adapt. So often jogging is a common thing we get asked about, and we're actually happy for, the experts we worked with are happy for women to continue to run throughout their pregnancy. And there was a study published by the Part Run group who showed that there wasn't any complications related to that. But yeah, women just listen to it and have to adapt their exercise. And so we wouldn't recommend, if you have never run before, I wouldn't recommend starting running in the third trimester, but it's obviously quite sensible. Most of it's quite sensible advice. And it's kind of, and just listening to your body, moving gradually, and slowly building up. Don't those are the main bits of advice, really. Yeah. So, and it's keeping moving, being positive about most types of activity are fine. Yeah.